Welcome back. Oh. So, this is the second workshop session. We've got, just so that I remember the names and not embarrass myself, Irene Buteman, James we've met, David Caesar, and Stuart Graham. So what I'm going to ask, apart from James, is that for our other panellists to take 2 minutes to explain to the group where they're coming from, and that might help us then frame some of the questions around the two workshop sessions that we've had up to now. I have questions in reserve, just in case, but don't rely on them. Thanks. So, Stuart, over to you.
Thanks very much. Is that on? Yep. Can everybody hear me okay? Is that okay? So we were speaking in our workshop about community planning partnerships and community planning, what they could do. Started off saying what's worked well so far. A couple of things we came up with is that partnerships have now got a bigger focus and understanding of inequalities than they previously had. We saw the local outcome improvement plans as being a quite good focus for that sort of thing. We then kind of moved on to the opportunities to improve, and there was quite a strong sense around the room, particularly from third sector colleagues, both local third sector colleagues and national third sector colleagues, that they felt that community planning partnerships could sometimes be a bit impenetrable in terms of getting in there, influencing, and also bringing to the table what they actually do and what they could value from there. We also spoke a bit about the necessity to keep focusing on our longer term priorities and not flit about and lily pad from one priority to the next as the flavour of the month changes, that kind of thing. So in terms of our practicalities, we thought about identifying those long-term priorities and sticking with them, trying to identify what the case for prevention was, so building that case in monetary case, but also in terms of the benefits as well. We spoke about implementation science, a new thing coming in, which is about how you approach change, and that's a kind of social work type thing. But that seemed to be really positive in terms of evidence and how that change would go. So that's just some of the things that we said. We also said that community plan partnerships could also have a role at feeding up to Solace and Scottish Government and other bodies there as well. So some good stuff, lots to improve on, a couple of actions to take. Hope that was 2 minutes or so.
Thank you. So we were looking at the role of planning in place when it comes to delivering on the public health priorities, and we began by the bigger context of the impact of all of this into climate change, which was sort of broadly agreed that the climate crisis is one of the bigger aspects that public health reform itself is feeding up and into. The role of planning in place, we ran through what are the key principles that planning and place-based approaches and working out of our silos can contribute to greater well-being and greater prevention when it comes to public health as well. And we had a chat around what those principles were and the need to make sure that they were tested locally and that we were feeding up locally using tools like the Place Standard tool as one means of doing that, and that it was getting that local buy-in to the change that you could make in an environment that would create healthier environments, but getting that buy-in from communities was what would give that overall stewardship as you were moving on also.
Thanks very much,
Adam. Thank you. My name's Dave Caesar. I have the role and I suppose responsibility of Head of Leadership and Talent Management for Health and Care in Scottish Government, which is relatively new, and I'll happily answer any questions on it and take some suggestions, which I'm sure there'll be lots of through the rest of the afternoon. I'm also one of those difficult people that work in healthcare and so are unwilling to give up any of the resource that we've so carefully curated over the last 70 years. And in that, I'm a doctor, so I work in emergency medicine. And so I'm even more annoying because I'm one of those people that then raise a stink when anything it might change. So you can ask me about any of those roles if you like at any point, and I'll try and answer them politely. Really, the reason why I moved into leadership was because, or moved into with an interest in leadership, was because the issues that you've been discussing today are right the way through our system, and we can argue about what the system is, if you like, over the next few minutes. But all of the issues are apparent in any setting that you go at any level out there, at an operational level, at a tactical level, at a strategic level. And one of our tasks in leadership and talent management is to take stock of what the system is currently struggling with, collaboration, a collective approach to problem solving, and to be more forward focused and more forward thinking rather than reactive and input focused, all require us to change the habits of a lifetime. That's not just people like me, that's people like you, it's people at every point in the system, and it's our citizens and the people we go home to at night and everyone else. We need to somehow change the habits of a lifetime, and that is going to require a huge amount of heavy lifting. So we almost need to escape this huge gravitational pull of what we expect our system to deliver for us, and we all need to show leadership in that space. So that is not down to an individual person, people, bit of the system, organisation, whatever. That's going to be incumbent on us all, and that's really tough. So that's what we're trying to encourage in our health leadership and talent management program called Project Lift. I'll talk more about that later, but I'll stop for now. Happy to take any questions.
Thanks, Dave. So, throw it open to colleagues for any comments, questions, or observations. And Mark's ready with the roving mic. There we are. One of our colleagues there.
Hi, I'm Evelyn McHugh, Co-Director of the Public Health Reform Programme. And this is just really to get the conversation going. But I think we heard earlier, well, we've had a lot of discussion about community planning and how central it is to bringing partners together and making things real at a local level. We also heard this morning that community planning can be very variable, and the experience of it is very variable. I've also, through the engagement that I've been involved in, heard from local partners that the engagement of NHS leaders can also be very variable across the country, huge range, some very involved, some less so. So I guess my question is perhaps how can local partners help NHS leaders to embrace the opportunities that local community planning partnerships provide for them to engage in preventative work that will ultimately reduce demand on health services.
So who wants to have a first go at that? Stuart.
Okay, that was a big question. I think some of the discussion that we had was about some good practice examples that we had through community planning partnerships. But one of the things that we said was that we aren't always very good at taking those localised examples of good practice and kind of spinning them out into other areas as well. So that's maybe something that we should have a look at, is to say what have we got that's actually worked well, why has it worked well, and can it work well in other places as well. I think one of the issues that we have that we need to recognise, and as you said, there's lots of variability around, and part of that variability will be the way that individual community planning partnerships are structured, and also the relationships between them. So I think sometimes learning about the relationships that are involved and how we build those relationships, and how we make sure that one organisation's priorities are understood by another organisation, and that we're actually asking each other to help out with those priorities. I think that's something that we can hopefully develop.
James, you want to offer any observations on that question?
I think variability in itself is not necessarily a bad thing, but I think it's a good thing. But I think I take the negative variability you're referring to. I think one of the things is that we need to start more conversations, and it needs to go well beyond the formal community planning partnership. I conceive of community planning partnerships as not just the institutions or the chiefs. It's got to go right through the system. And I think we have to be very open and address the fears that exist, say, in the NHS. They're after our money, which Dave was alluding to there, and it's right. We need to look at that and address that. And I don't think we really do. I think, you know, at every level in politics, we run away from that, and I think that's deeply unhealthy. We do need to start having that kind of serious conversation. And it's not going to be easy. And in truth, when you've got limited resources, folk will fight for those resources. And we've got to say, well, justify that. And what are you going to do that's not going to undermine the stuff that everybody's colleagues rightly are going to want to defend? But I don't think we have enough conversations and dialogue and such like, and understand where each of us. Empathy is hugely important. Understanding where others are coming from. I think we're very good, and that's the silo mentality again. We're very good at looking at it from our own very narrow perspective.
Irene?
Yeah, this came up certainly within our workshop around building that local capacity, and I would agree that there has to be a flexibility. Every council's different parts in a council area are very varied as well in what you're dealing with. But from the context of looking at the contribution of place-based approaches, which is pulling together all of those organisations that should already be inputting into community planning, the best examples that we've found are where you've had somebody from one professional group or background taking the time to actually go and spend time in the office of another. Be that somebody going from public health background and sitting within community planning partnership, or sitting within the planning aspect of creating a great place. Any of the good examples where they've really enhanced their understanding has been where you've had that crossover and those kind of secondments that have enabled that real local understanding. And that's that pulling together of a good resource then, and making the most, as you were saying, about 1 + 1 making 5 when you do that.
Dave?
So it's a great question. So I can answer it more confidently from a health perspective, obviously. And I'm keen to also understand the other perspectives. The first trick of system change is to understand the type of system that you're trying to change. And I think this is the thing that we trip up on over and over again, which is that we assume that our system works like the organogram that we have on the wall. And it doesn't. It's not a factory. We may well have hierarchies of decision making, but first of all, information has become profoundly more democratized in the last 10 years than it has ever been. So people are freer to make the choices that they see as being the best fit for them than they have ever been. The second thing is that variability is inevitable. So because we exist in a human system, dealing with humans and human issues, and those humans will have extraordinarily different lived experiences and a different perception of the things that they see in front of them, so will naturally make different decisions. If we can't understand what constitutes engagement on a human level, rather than on a mechanical organogram type level, then we will not shift the system. So we have to change our approaches, we have to change the rhythm of how we influence and engage, to enable us to understand that more profoundly than we have done before. Because our workforce certainly doesn't listen to what the top tell them. I can tell you that now, in case you were thinking that they did. They make decisions every day based on the situation that they find in front of them, and that sometimes will coincide with what the strategy says, but often it won't. Sorry to break that news to you. But they will, when they are engaged, make a different decision. And it's engagement that makes the difference. It's not what's written on the wall. And I think understanding your system and recruiting leaders that understand how to engage that system, performance managing leaders in a way that helps them be encouraged to understand how collaboration and engagement works, and then enabling that awareness and those generic skills to be encouraged, as they are not at the moment, because our systems of accountability do not match up to actually the system in which we operate, will be the ways in which we can start to nudge the dial, in my view.
Thanks very much, panel. Any other questions?
Thank you, Mark. Angela Leach, currently East Lothian Council. I think the observations from the panel and the observations and the feedback from today has been really, really worthwhile. I mean, there's obviously a lot of great ideas and some tremendous practice that's taking place across the country. I suppose it's picking up on the engagement part. In local authorities in particular, we've been tasked over the last few years on a process of greater community engagement. And I just wonder from the panel what views there might be in terms of how we can promote this for health and well-being. But I'm conscious that engagement isn't just for the prerogative of local authorities. It can be something that all partners, and when you think of the engagement that our health colleagues have with our citizens, how best can we change the culture of engagement and make it everybody's business, as Angela said previously, and how do we capture that so that it's a shared endeavour that we're all embarking on?
Who wants first go at that? Irene, on you go.
Certainly within place-based approaches, then it has to be a shift and a mindset change in how we go out and speak to communities. For years I've gone out speaking from a planning department about planning issues. A community doesn't want to talk to you about any service area. A community wants to talk to you about their place. And then it's for the professionals and all of those groups that are sitting behind that to decide how can they pull that out, tease out what the issues are in an area and actually see where they need to work together to address certain priorities. As far as I'm concerned, that is community planning. That is good community planning. You've got those organisations around the table to actually take that forward. The use of something like the Place Standard tool is particularly good because it immediately engages a community in a conversation. It's very easy to run through questions and it stops a conversation with a community getting caught in one issue, which we all know can frequently happen, where it would be of more value to get that full conversation in the round about a place. So to get out of silos, though, for me the overall question is just as if you want to get out of silos, stop measuring by silos, stop doing community engagement in silos as well.
One observation I would make on this is that if you look at it from the point of view of the citizen and the community, people don't look at the public services in the way that the public services are structured. And I'm often struck by the fact that whenever, for example, people have got a complaint about the local GP service, and who do they go to? They go to their counsellor. Why do they go to the counsellor? Because they don't know who else to go to, and it's not the wrong decision. So I think we've got to get into the mindset of the citizen and the community and work that way, rather than say we've got these institutions and we should engage. We're not. I think we've got to often think we've got to turn the whole system upside down in that way and put citizens and communities uppermost. And that means really tackling some of those silos that have just been mentioned.
Sure.
I think one of the discussions we had in our workshop was third sector organisations and how they can play in, and I think they're really vital in terms of community engagement for the reason that they're very often closest to the people that we want to talk to, and they already have a relationship with them. Through our Tackling Poverty Commission that we had in Renfrewshire a number of years ago, one of the early decisions was that we weren't going to commission consultants to go out and speak to people and bring the information back to us. We were going to go through the third sector organisations and get some authentic lived experience back from them, because they knew the people that we needed to speak to and they knew the stories that we had to hear as public sector organisations. I think as community planning partners, it's exactly right. People sometimes won't be wanting to talk to us about a particular issue on the particular day that we want to talk to them about. There may be a range of other issues that they want to talk about at the same time that's more important to them. And it's about using the resources that we have available. So sometimes it's not the council that's the best person to go out and engage with people. Sometimes it's the fire service, sometimes it's a third sector organisation, sometimes it's health people. So it's about using the resources that we've got, using the connections they've already got, and trying to get those kind of authentic lived experiences into our engagement in a way that actually can influence the outcomes.
So I'm not going to disagree with any of that, and also if this is a sort of confessional moment, continue that theme, which is that health big health, I'm talking about as in sort of institutional health, have done this awfully forever, I'm pretty sure. So, and we're doing it as badly now as I think we've ever done. So it really gets into the one of the elephants in the room, and there'll be a number, which is around the power dynamic that we still hold as a society. So we have, so I as a doctor have power and status over people that come and see me, partly because of the information that I hold and partly because of the service that they require. And this whole notion of citizen engagement and shifting it to a mutually respecting peer-based relationship with societies and between societies, I suppose, and between collections of individuals is something that is shifting. Actually, it should shift us on its axis, so that we are all much more horizontal. We need to do that organisationally. We need to do that professionally on a one-to-one basis. We need to do it in our teams as well. And again, it goes against all the things that we used to measure as being really important in life. And many people still do measure as being really important in life, which is around our identity and our status in that moment. And it's really tough. We all have to think about how we bring ourselves to work and to bear in those instances, and we're all guilty of it. We're all guilty of it because it takes time and effort to shift away from it, and we have to make sense of it. It comes back to that purpose. What am I there to do? And to develop a sense of servant leadership and to be a public servant is the thing that we've kind of lost sight of, I think. And we need to re-find it.
Thanks for that, Dave. Is there a final question anywhere in the room? Thank you.
Thank you. I'm Claire Stevens from Voluntary Health Scotland. Earlier we saw a slide which showed milestones in the development of Public Health Scotland from now through to a 3-year point, and it focused very much on the internal sort of organisational arrangements of Public Health Scotland, including what seemed to be an anticipated reorganisation at the 18-month point. Could the panel say what difference they think Public Health Scotland and public health reform will have made or should have made or could make in 3 years' time? So for the citizens that Angela was talking about, what difference might they notice in public health in 3 years' time? Thank you.
That's a really good question for the panel. Irene, why don't you kick it off?
Yeah, I'll go for it. Still sitting with the hat on that I've been hearing talking about today about place-based approaches, stepping out of silos, looking at that environment, our physical environment, and how it interacts with an economic environment, social environment, our online environment. I would like to see a Public Health Scotland that is supporting high-level recognition of the areas where those place and planning principles feed into prevention when it comes to Public Health Scotland, when it comes to promoting public health. I'd like those to be supported so far that Public Health Scotland is a consultation authority on population health, so that it can actually be there as a help and an assistance with teeth, so that when there's change happening in an environment, they will be there having that oversight. Now, that requires them having a remit to do that. That requires them having the skills to do that also, and to be able to support as we move forward in real long-term preventative interventions in places as we see those places change. That's what I would hope that would be happening in 2-3 years' time. That would be great.
Thanks. Dave?
So there are 3 questions, I think, in there. So there could, what could they do? Well, it's a massive opportunity. It's a massive opportunity to really embrace all of the challenges that we rehearse over and over again. We know what the problems are. We know what we face, and I think there is something about moving the public health community into the mainstream, I think is the real opportunity, which is that the issues around our poor health, our poor life expectancy, absolutely cannot be solved by healthcare. And that's me as a doctor saying, I cannot fix these problems. So we need to bring that acceptance into the mainstream. And that's going to be difficult because that's not going to be a message that many people want to hear. But it absolutely needs to be heard. Because only when we get acceptance of that will we start seeing meaningful action, and we need meaningful action. So we can't go round the evidence cycle over and over and over again, telling everyone how unequal we are and how poor our life expectancy is and how we rank. So our outcome shouldn't be, well, we're moving from 19th to 18th in the European League table, if we're still in Europe. So that can't be the measure of a successful country. It should be something far more tangible and meaningful to citizens, so that when my kids go to and come back from school, they have had a holistic health improving experience, both mentally, educationally, spiritually, physically, so that they grow up healthy and with every opportunity to thrive when they then take their own steps into adulthood to contribute to our country. And that they then don't learn the bad lessons that their parents have, which is part of our problem about facing up to the intergenerational issues that we have in this country, which we also don't accept. So we still think that children are different to adults, and yet we put them with them all the time, and they inherit what is given to them by their parents. So we need to somehow break all of that cycle as well. And these are really, really tricky issues. So I think shifting it into action, being an absolute advocate for what might be unpopular to many established views of the world, and then only then will probably the resource start to shift. But if we haven't won the hearts and minds, nothing will change. I don't expect that to happen in 3 years. So that's the good. The will might be how we set that up and what we need to have in place to enable that organisation to link effectively, to collaborate effectively, and to message coherently. Because that's one of our biggest barriers, is that it gets diluted in all the other chaff that's out there. So.
Sure.
I think sometimes I look back on other things that have maybe happened in the past, and it was alluded to in our workshop, things like the way that the culture changed around things like drink driving a while ago has been a way in which actually changing the public perception, but in this case changing the perception of the various different partners that are involved in it, can actually make a real change on the outcome and impact. The example I would probably point to more recently would be the Early Years Collaborative, which I think did a lot to raise the understanding among people of the importance on a lifetime cycle of early years, and how that changed the perception of groups of statutory sector officers, third sector people, people all over the system, if you like, about what their role was and why it was important and what the intervention points were. So I think if Public Health Scotland can provide us with the evidence, provide us with the pointing towards where the intervention points are, that each of us can confidently take steps as a kind of joined up partnership, then I think that would be a measure of success. And as I say, I think we've got examples of how that's changed in the past that we can actually build on. So I'm hopeful that will work in the future.
Thanks very much, Stuart. James?
I think it's a really, really important, difficult, and actually a dangerous question. And what I mean by that is that I fear that we'll have targets and we'll say we're going to do X in 3 years, 5 years, when actually much will be outside our control. We don't know the impact of Brexit. We don't know the impact of, well, a hell of a lot of things by definition. We just don't know. Who would have known? Well, I certainly didn't know that thousands and thousands of people are going to lose their job because Thomas Cook collapsed. Things can happen and they get in the way. So we need to be flexible. What I would like to see over the next 3 years and beyond is evidence that we're on this journey and we're moving on this journey at pace. And that sounds a bit waffly, but I actually think it's dangerous to tie it down too specifically. Having said that, some of the specifics we've had of examples of policy initiatives are important, and if we can do that, for sure. I think when I say evidence, the session I was in before this one was a wonderful discussion there on what we mean by evidence and the different forms of evidence and the different forms of measurements, like qualitative and quantitative. And I think we really have to grab that. And this is actually, to come back to something that was mentioned earlier, I think one of the things is we've got to look for common ground. And there is a tendency for local government people to think of health as got all the resources and such like. There's often a lot more common ground, because a lot of the complaints I hear from health folk are very similar to local government and to police. I do more work with cops and probably any of the other public services, and that's about target-driven and all the rest of it. And I think there may be scope for actually working collaboratively on a lot of that common ground, and we might be able to move. So let's be very careful that it's outcomes, not outputs, inputs and such like that count, but actually a lot of it is going to be outside our control, and a lot is going to require significant courage on the part of our politicians as much as anything else. It will depend on, frankly, big decisions on our fiscal arrangements, our taxation, our benefits. So you see why I'm a wee bit disappointed and frightened to make any hard things, and why I'm, in that sense, pretty pessimistic.
I'm not going to finish on that note. Thanks, James. No, I think there's a number of really important points. One is we want to be able to chart progress, that we've got the organisation established and embedded. But in my experience, and maybe it's shared over with a number of you, is that sometimes when you set out milestones, they become millstones. And it's another part of that target mentality, that you said by 18 months you'd have done this and you haven't done it. Because I go back to the point that Angela made this morning, some of the things that we are talking about are generational, the changes that we want to see. I think that part of the challenge that will face Public Health Scotland as an organisation, it'll be for Angela, myself, our executive team and the board, to begin to have these conversations, to say how do we nudge the agenda that allows these conversations. At the moment, and because what we're actually saying, there is an invitation for everybody to participate. There isn't just Public Health Scotland, it's Scotland's health priorities. Public health priorities, that's the real win for all of us here. So on that note, I'd like to thank the panel for their contribution this afternoon.
Much more positive.
And to thank all of you for coming along today, to giving your time. There's an awful lot of stuff that we've picked up that we'll try to incorporate into our thinking. A lot of the ideas that come up from the workshops and from the two very good plenary sessions that we've had. Copies of the slides will be available to you if you want them. We would put that up to the website.
Yeah, no, we'll send a wee link out to everybody so you can access all the slides and you can download them all and you can peruse them at your leisure. Okay.
And when I was doing my little talk earlier, a presentation earlier on, I did say that, in kind of answer to that question, would there be a forum like this at some time over that 3 years that revisits some of this conversation? To say, has that begun to work? Have we actually begun to establish dialogue cross-sectoral? And with that, safe journey home, everyone. Thank you for coming.